Now, so once you have decided that the patient is going to need fluid, then you need to decide how much fluid you are going to give. So what I am going to do in next 12 minutes or so is talk about what is the effect of positive fluid balance on outcomes, particularly in relation to patients with septic shock and ARDS, the things that we see most commonly in the intensive care units. If we are not worried about positive fluid balance and if we under resuscitate the patients, does it harm the patients? Then I will talk a little bit about restrictive fluid therapy, which is mainly been practiced in the perioperative period and not so much in intensive care units, and whether we can adopt that to intensive care. And then I will talk about something called as optimization of fluid therapy for individual patients, and if at all that is practicable, how to do it. So this was a retrospective review of the vast study patients, which was published a couple of years back, and this study was published last month. And they looked at fluid balance on the at 12 hours, and they looked at the fluid balance on the fourth day, and they also looked at the CV fluid balance on the at 12 hours, and they looked at the fluid balance on the fourth day, and they also looked at the CVP values in these patients, because surviving sepsis guidelines suggest that the CVP should be between 8 and 12. And then they divided these patients into different quartiles and looked at what is the effect of the fluid balance on mortality. If you look at the 12-hour fluid balance, you can see that the patients with the lowest positive fluid balance had the lowest chance of dying, as the fluid balance progressively increased or became more positive, and the same held true for the fourth day. So positive fluid balance is an independent predictor of mortality. Surprisingly, when they looked at the CVP values and its effect on the mortality, the patients who had CVP of less than 8, surprisingly, meaning that the target suggested by surviving sepsis campaign was not achieved, those patients had the lowest mortality, as shown by the graph on the top. So they concluded that optimal survival in the vast study occurred with a positive fluid balance of approximately 3 liters at 12 hours, and subsequently the patients who diuresed by fourth day survived. This is a very famous trial. I don't need to go into too many details. About 1,000 patients, out of which 500 were given liberal fluid strategy, and 498 patients were allotted to conservative strategy. We must, however, remember that this study had a very, very strict fluid management protocol. Even in this study, when the patients were in shock, they were allowed to give fluid to these patients. And what they found was that though there was no improvement in mortality or weaning, patients who had a negative balance in the conservative strategy, the oxygenation was improved and there was no increase in organ failure. Now that is our biggest fear when we try to restrict fluid, that the patients will have organ failure, renal failure, hypoperfusion, etc., etc. But this study showed that with careful monitoring and good titration of fluids, the mortality does not increase because of organ hypoperfusion. Now, all of you must remember the ARDS study, and after this study was published, the ArtsNet investigators went back and looked at the data of their own patients who were involved in low abdominal ventilation study, and they also found that patients who had less fluid balance or more negative fluid balance, they had, on the fourth day, they had lower chances of dying. Now, coming to the moderation, the thought about moderation has been there since 1967. So the authors say that the objective of care is restoration to normal physiology and normal function of organs with a normal blood volume and functional body water and electrolytes. This can never be accomplished by inundation, giving lots and lots of fluids. So the rationale of restricted fluid therapy is that because there are lots of effects of fluid overload, if you look at the data, patients who had perioperative weight gain of only 10% or less than 10%, the mortality was much lower as compared to those who gained more than 20% body weight. So does this restrictive strategy work? Unfortunately, the data is only in the perioperative period. The first one was a thoracic surgery patient group where they restricted the fluid intake intraoperatively, and they showed that there can be reduced pulmonary complications and shortened hospital stay if you adopt a restrictive strategy. And similar studies have been published in colorectal surgery, and this meta-analysis also suggested that you either restrict the fluids or you do individual optimization for the patients with the esophageal Doppler monitor. We also know from the trauma experience that if you do the first part of the damage control resuscitation, which is permissive hypotension, tells you that give reduced amount of hypotensive or balanced resuscitation, and this has not been shown to work. This has been shown to work and it's widely practiced in military settings. However, either you give fluids liberally or conservatively. We can't give a blanket order as to give 2 liters, 5 liters, 1 liter, 20 ml per kg for all patients, and therefore one size does not fit all. Now, when you look at that graph, you can have patients on the x-axis, either dry or wet, as you go away on the x-axis, and you can have perioperative morbidity list. And the U is the fluid loading curve. As you go from giving less fluids, if you give too less, also the morbidity will be high. If you give too much, also morbidity will be high. And you want your patient at that stage, and this point will be different in each patient, and therefore the concept of optimization came in, and as Dr. Prayak told us, lots of options are available. What we need to see is whether these options work. Unfortunately, again, the data for individual optimization is only in the perioperative period. This one study, which is an old study, they looked at managing the fluid intake, looking at extravascular lung water of patient and restricting it to less than 7 ml. So what they did was, if the patient became hypotensive, and they were all ARDS patients, they used vasopressors and restricted their intravenous fluids. If the patients were normotensive, they were given diuresis and vasodilators. Another group had wedge pressures, and they were more liberal with their fluid management. What they found was the patients who had lower extravascular lung water, we also had lower ICU days, as well as ventilator days. There were no adverse events from fluid restriction, and patients who gained less than 1 liter of fluid by 36 hours had survival of 74% versus 50%. Now, unfortunately, this study was not numbered for mortality. Another study again looked at individual optimization using esophageal Doppler monitor, and what they found was that if the corrected flow time was low, they would give a bolus of colloids. In the other arm, it was a normal fluid strategy, and at the end, they found that the patients had decreased length of stay in the hospital, reduced other types of morbidities, and early resumption of orals. This is data from Tata Memorial Hospital. We looked at 87 patients who were undergoing esophagectomy, and we know that central venous oxygen saturation is a very good surrogate marker of cardiac output. So this was a prospective observational study, and we took samples at 2 hours and 12 hours post-op, and automatically the patients divided themselves into 2 groups. Those who had SCVO2 greater than 70% at both intervals obviously had normal cardiac output, and the other group who had less than 70% SCVO2 at one or both intervals. Now, patients who had low SCVO2 had more post-operative complications. So maybe we can target SCVO2 greater than 70% as a method of fluid optimization, because it is simplest to do. Most patients when you are treating them. So that is something which can be looked into. Dr. Prayak talked about pulse pressure variation, and this study looked at optimizing fluids by reducing the pulse pressure variation to. At the end of the study, they found that a protocol group at the end of surgery, but they were better perfused. They did not need vasoactive in the acute phase of the inciting insult. So the difficulty, as Dr. Prayak alluded to earlier, is not in a resuscitated patient, not resuscitated patient. Difficulty comes when you are third day into the ICU admission of the patient, and you don't know whether to give conservative or restrictive approach. I think because of the new gadgets becoming available, probably individual optimization is the way we will probably go. I thank you very much for your attention, and I wish all your patients optimized fluid therapy. Thank you.